And the study he's talking about from the Cleveland Clinic, Rishi's study, we prospectively followed, I think it's about 26 patients that were enrolled, and we put them onto a fixed dosing regimen of Eylea, 3 injections after switching them, and then every 8 weeks. And at the 6-month time point, the patients gain about 7 letters of vision, which is, you don't expect to see such a large improvement in such a short period of time. So,
right. And especially the hardest to treat patients.
Right.
Yeah, exactly.
Chronically treated patients,
Yeah.
exactly.
Why do you think this is, Jason? Do you have any? You're one of those brilliant thinkers. What's the reason for this?
I think that there's a lot of things that were thrown around. I think it's already been mentioned, some of the ideas. Tachyphylaxis makes sense for people that have been on chronic therapy, but I have patients who were on 1 or 2 doses of Lucentis or Avastin and then get switched, and they seem to respond dramatically, so I can't consider that a tachyphylaxis issue. I think the placental growth factor is something to consider. We did our own prospective study, and what we found is that a majority of the ones that are our chronic patients have features of a thick choroid that might imply some underlying central serous. They have some patterns on ICG that suggest polypoidal. So many of the ones that we're considering poor responders have these other factors. And if you look at the literature, they've done studies on some of the growth factors or angiogenic factors in AMD, and placental growth factor never seems to be on the list. It certainly is on the diabetes list, so I look forward to seeing the differences in diabetic retinopathy among the drugs. But for AMD, it's never been considered to be a big player. But that's in, quote, typical AMD. The question is, what about the ones with central serous components? What about the ones with polypoidal components? Maybe placental growth factor does play a role here. That's one possibility. The second may be the binding affinity, this tight binding affinity that Eylea has. If you've got a lot of drug, it doesn't matter what your binding affinity is. If you have 1,000-fold of Avastin, Lucentis, and Eylea all going after the VEGF molecules, it doesn't matter what the binding affinity is. But as soon as the drug levels come down, it does become more important of how much free VEGF is floating around. And if the binding affinity is tighter and longer, it'll hold the VEGF and prevent it from hitting its receptor. And if you think about it, most of our bad responders have RPE elevations. Most of them are occult type CNV on a fluorescein. Most of them have at least some degree of sub-RPE fluid. And if most of the CNV is under the RPE, if you think about it, from the moment we inject any of the drugs, regardless of the size of the molecule, under the RPE is the lowest concentration of drug from day one. So that would be the area where binding affinity might play the biggest role. So it may be that something as simple as the affinity of the molecule for VEGF may be the driving factor here. The simple fact is, great ideas. I sounded really good telling you that. We don't know.
Yeah, I mean, that was, anecdotally, when Eylea first came out, it was those patients that were so striking for me just in clinical practice. And it is the one subset that when a patient comes in primarily that I am treating with Eylea off the bat, is those are patients when they have a lot of pigment epithelial pathology that's a component. Those are the people who, if they're asking me, what do I think is, what would I recommend, that is where I often will consider starting with Eylea as primary therapy.
Great. Well, I think we've... go ahead.
Oh, sorry. We did keep in mind that it's like a 1-to-1 binding with Eylea as well as the other thing. That whereas the other ones with Lucentis and Avastin, you can get dimers or clumps. So if you have 1-to-1 binding and you've clumped all these molecules, you might not have any active molecules left to bind VEGF, X days later. Whereas if it's 1-to-1 and that one hasn't found its partner yet, it could still float around and find something to bind to. That could be another reason why we're seeing better effects or longer duration as well.
Great. So we've spent a lot of time today talking about the diagnosis and treatment of macular degeneration. Any last-minute comments, future directions that you're looking forward to?
I'll start off. Number one, we have a long way to go with this disease. I remember when the Lucentis data first came out, and I was standing next to an investment person, and they know that I'm involved in a lot of research, and they turned to me and said, "So, we're going to be pretty bored now that we have a problem solved in AMD." And I just kind of looked at them and said, "What are you talking about? 90% less than 3-line vision loss at the end of 2 years is great data. I mean, that's wonderful. But that means 1 out of 10 patients we see is going to lose 3 lines of vision. 35% 3-line gainers is great, but that means 70% of our patients aren't gaining vision. So great first step, but there's a long way to go. We need to control the disease. We need to control fibrosis, prevent atrophy, restore RP function. I think we've taken a huge step forward, but I'm looking forward to the next big thing to come along. So thank God at least we can control our patients with these drugs. Now give me the next thing.
Well, thank you all for being here. ARVO 2013. We look forward to some data that's coming out at this meeting, and we'll hopefully have a roundtable to discuss that in the future.
Thank you very much.
Thank you.
Thank you. Thank you.